Yes, please.
Yeah. Good morning, all my friends over here in India, and good evening to all those in United States. Welcome back to this 95th edition of our weekly webinars on COVID-19. And today we have a wonderful speaker, Dr. Vasishtha Tatapudi, the nephrologist, assistant professor of nephrology. And he's an assistant professor of medicine, and he's the program director of transplant nephrology. And the proud son of our Dr. Raviraju. And he's in his father's footsteps, taking up the nephrology and reaching to the greater heights. And today, Dr. Ravi Sharma is supposed to moderate this particular session, as Dr. Ravi Sharma has been very busy. Dr. Kairam and Dr. Buddharaju will take over, and they will moderate this session. And for all those who have been listening to these webinars for quite some time, you might feel that this is a topic which has already been covered, but one has to understand that there are small deviations in the sense that there are some intricacies that we all should know. So though the kidney disease has been covered earlier, the kidney in the long COVID as well as in the transplant biology needs to be understood by some of us. So as we move forward, it's always important that we know the intricacies of all these the disease patterns. Similarly, we have taken a lot of sessions on psychiatry also. We are going to have one more session on psychiatry next week. So the whole aim of this particular session has been to give in-depth knowledge to all those who have been continuously on this forum. So we have requested Dr. Vasishtha Tatapudi to tell something about the acute kidney injury as well as long-term kidney injury, as well as what happens in the patient who undergo transplantation, renal transplantation. So without wasting much time, I would request Dr. Kairam to introduce Vasishtha Tatapudi.
Thank you. Dr. Tatapudi's name is so popular with the last name that everybody should have now figured out who he is. He came to New York City and did a residency in internal medicine in Dr. Chilimuri's department at Bronx, Lebanon, then went on to do a fellowship in nephrology. He's now appointed as a program director in the Transplant Nephrology program at NYU School of Medicine. And I have spoken to him for the past few weeks, asking him to speak about both acute kidney injury and the nature of the kidney involvement and kidney injury in individuals who already had received a transplant or on the transplant list with end-stage renal disease. So that may be too large a topic, but right now we are looking forward to hearing his experience and knowledge of the field, because it seems clear that even if you survived COVID, you still could have bad kidneys that would affect you in the long run. So, Vasishtha, take it away.
So first of all, thank you, Dr. Sudhakar, Dr. Kairam, and Dr. Chilimuri for inviting me. I know there are several stalwarts in this forum here, so I'm just going to say I'm honored to have been invited. I'm going to try over the next 40 minutes or so to share some of my experience taking care of patients with COVID as a nephrologist in New York City, which, as you all know, was the epicenter of the pandemic when it reached the shores of the US in early 2020. But I'm also eager to hear some of your insights from India. And also, since I haven't met with Dr. Chilimuri in a while, perhaps for his insights as well. So I'll start off by talking about something again that all of us know, but I think bears repeating. The pandemic started in the city of Wuhan in Hubei province in China. in late 2019 and became a pandemic of epic proportions. And these are data that I pulled from the Johns Hopkins University dashboard earlier today. And these numbers keep ticking up every second. And the global deaths have reached a staggering number of 5,042,829 as of a few hours ago. I think we're all sort of familiar with this number, but we've become jaded hearing these numbers every day. But I think, like I said, it bears repeating, and we should never forget what we've been through these last couple of years, if for nothing else, so that we're prepared for this or something like this in the future, and take steps to prevent something like this from happening in the future as physicians and as members of the medical community. COVID-19, as you all know, manifests primarily as a pulmonary infection of varying severities. But COVID disproportionately affects patients with pre-existing comorbidities, such as kidney disease. And hopefully that's where I can share some of my insights, and perhaps because this topic has been covered, put my spin on it. But as medical professionals, and including nephrologists, we're all tasked with rapidly adjusting our practice to curtail the spread of the virus, but also our role is also to provide life-sustaining care to these patients during the pandemic. I'm going to talk about COVID as it relates to acute kidney injury, as Dr. Kairam had mentioned earlier, and also chronic kidney disease, end-stage kidney disease, and transplantation. I'll begin by talking about the complex interplay between COVID and acute kidney injury. So this is the 10,000-foot view is that COVID is causally related to acute kidney injury. And acute kidney injury is associated with adverse outcomes. But if you look closer, it turns out that in patients with COVID-19, acute kidney injury is associated with astronomical odds of adverse outcomes, not just mortality, but also length of stay in the ICU and requirement for mechanical ventilation. And acute kidney injury is an independent risk factor for mortality, even when adjusted for several comorbidities. In other words, statistically speaking, acute kidney injury mediates the outcome in patients with COVID-19. The other thing that's important to think about when talking about COVID-19 and acute kidney injury is the mechanism of injury that leads to renal failure in patients with acute kidney injury. At this point, it's still not clear exactly what leads to acute kidney injury in these patients. It may just be hemodynamics and cytokine release, but it also appears that there may be some direct impact with viral particles infecting the kidney itself. And I'm going to talk a little more about that. So as you can see, it's a complex interplay. And these are some data from the New York metropolitan area. This is data from a retrospective study from 13 academic centers and community hospitals from the New York area that included more than 5,400 patients admitted, hospitalized with COVID-19. Acute kidney injury occurred in 36% of those patients, and that's a pretty high number if you think about it. And of those 36%, approximately 14% required a kidney replacement therapy, which includes hemodialysis as well as peritoneal dialysis. And if you do the math, 14% of 36% comes to roughly 5%. So that's 5% of patients hospitalized with COVID-19 who require kidney replacement therapy. That might seem like a small number, but what I would suggest is that a a small percentage of a big number is still a big number. So the denominator here, as a result of the widespread pandemic, is big. And that leads to high numbers of patients requiring dialysis. Mechanical ventilation seems to be associated with the incidence of acute kidney injury, and that should come as no surprise. It's merely a reflection of the severity of the disease in patients who require mechanical ventilation. And I think none of us would say that mechanical ventilation is causally related to acute kidney injury. This is also data from the same paper that suggests that as the severity of acute kidney injury increases, you can see here on the x-axis going from patients with no acute kidney injury to stage 1 to stage 2 to stage 3 acute kidney injury, you can see that the percentage of patients who died rises, and at the same time, the number of patients who required admission to the hospital increases, and the number of patients who were discharged safely from the hospital declines. So myself, and as I'm sure a number of you in Visakhapatnam also at a different time point experienced, this leads to a grim reality of a tremendous amount of mortality and morbidity. And I just put up a picture here of refrigerated trailers outside the hospital I work at, which were serving as makeshift morgues for patients who had passed away from COVID at the height of the pandemic in April 2020. And I hope we'll never live to see a similar day again. This data adds a more global perspective to acute kidney injury and mortality in patients with COVID-19. This is data from a systematic review of 13,000 patients from multiple continents, China, Europe, and the US. The authors of this paper included more than, systematically reviewed more than 20 cohorts from these countries and continents. And what they found was an incidence of acute kidney injury that was similar to the previous paper that I mentioned. 17% of patients hospitalized with COVID requiring meeting the criteria for acute kidney injury. 5% of hospitalized patients, almost identical to the New York study, required kidney replacement therapy, being either hemodialysis or peritoneal dialysis. And patients with acute kidney injury had a staggering mortality of 52%. So half of the patients who developed acute kidney injury during their COVID hospitalization did not make it out of the hospital. And this is sort of the bottom line of the systematic review. This is a forest plot showing. This is a forest plot showing the association between acute kidney injury and mortality in each of these cohorts from China, Europe, and the US. What you see here at the vertical line is the odds ratio of 1. The boxes here are point estimates of odds ratios, and the whiskers here represent 95% confidence intervals. And these diamonds here represent pooled estimates. And I'd like to draw your attention to this pooled estimate here. The odds ratio for mortality in patients with acute kidney injuries, 15.27, with a confidence interval of 4.8 to 48.36. So that suggests that the patients with acute kidney injury have a 15-fold higher risk of mortality than those who do not have acute kidney injury. That speaks to the impact of acute kidney injury in these patients. This is also similar data, but in a slightly different population. It includes critically ill patients with COVID-19. And this data comes from the STOP COVID investigators who performed a multi-center cohort study across 67 hospitals from the United States. They included upwards of 3,000 critically ill patients admitted to the ICU with COVID-19. And they analyzed not only the outcomes, but also the risk factors for acute kidney injury requiring dialysis. The outcomes are not surprising. The percentage of patients in this cohort who required dialysis of some form was 21%. And if I can compare that to the previous studies of hospitalized patients in New York and also from the systematic review, you will remember that the percentage of patients requiring dialysis was 5%. This study shows a percentage of 21%. And that's simply because the substrate and the patients going into the study were sicker. And these were ICU patients. But the grim reality in this study was 63% of those with acute kidney injury requiring dialysis died in the hospital. So that's more than half of them. And 34% or 1/3 of those who survived the hospital stay remained dependent on dialysis on discharge. And to the right here are the risk factors that were revealed from this study based on a logistic regression analysis. Again, similar to the forest plot in the previous slide, these are odds ratios, and you will see that the risk factors that became evident in this study for development of acute kidney injury in critically ill patients were numerous. Male patients, those with hypertension, diabetes, a BMI more than 25, those with underlying chronic kidney disease, stage more than 3, patients with high oxygen requirements, and those with D-dimer levels more than 2,500 were all at risk for developing acute kidney injury requiring dialysis. And I think it's important to think about risk factors because they're predictive of those who will develop acute kidney injury. And perhaps it gives us an opportunity to manage these patients differently and with the hope of preventing progression to or development of acute kidney injury. But any measures that we can take as physicians to prevent a disease from occurring requires an understanding of the causative cascade, so to speak. What is the mechanism of the evolution of the disease? At this point, I will say that it's still unclear exactly how COVID leads to acute kidney injury, but I think it's reasonable to say that in a great majority of these patients, it's the hemodynamics, it's the development of systemic inflammation in the setting of cytokine release and sepsis that contributes to acute kidney injury. But there are several studies, and I'll show you some of those studies in the next few minutes, that do suggest that the SARS-CoV-2 virus directly infects the kidney and causes certain changes both within the glomerulus as well as the tubular interstitium that both cause acute kidney injury as well as lead to long-term consequences. And of course, as you know, a lot of these patients who are admitted to our hospitals with COVID-19 for various reasons end up getting nephrotoxic agents, be they antibiotics or iodinated contrast for imaging, and that also contributes to acute kidney injury. And a tool that nephrologists have to assess or at least get at what the underlying cause of any given disease is the kidney biopsy. And this is data from a study that was done at Columbia University Medical Center in New York. And they looked at postmortem kidney pathology findings in patients with COVID-19. Essentially, it's a series of autopsies from 42 patients who died of COVID-19. These investigators reviewed the electronic health records to figure out the clinical and demographic data of these patients. And these tissues were evaluated by 2 pathologists independently. And they also used in situ hybridization studies to see if they could identify the SARS-CoV-2 virus in the kidney tissue. And here's what they found. They found their cohort included mostly elderly patients. 71 years was the median age. They were mostly male. A majority of these patients had hypertension and diabetes, and 94% of them had developed acute kidney injury. 8 of the 42 patients required renal replacement therapy, dialysis of some sort. Not surprisingly, they found that these biopsies, from these autopsies showed that the cause of acute kidney injury in most instances was acute tubular necrosis or acute tubular injury, as it is now frequently referred to by the pathology community. So most of them had acute tubular necrosis, but some did have fibrin thrombi, and 1 patient had collapsing focal and segmental glomerular sclerosis. And I'll talk a little bit more about that in the next few minutes. So, and the other surprising finding in this study was that the degree of acute tubular necrosis or acute tubular injury was surprisingly mild relative to the degree of decline in kidney function that these patients experienced. So there was a disconnect there, I'm loath to speculate what the reasons for that might be. This is renal histopathology from another study from actually live patients with COVID-19 who had acute kidney injury and underwent kidney biopsies. This is light microscopy from the proximal tubule. This is toluidine blue staining on epoxy sections. And this here is the proximal tubule. And as you can see, there's a lot of vacuolization in the tubular epithelial cells. And the authors also performed electron microscopy, and they suggest that this finding of tubular isometric vacuolization in these tubular epithelial cells corresponds to where the viral particles were found on electron microscopy, and I'll show you those slides as well. To the right here, you see a slightly different picture, also proximal tubular epithelial cells. You don't see vacuolization, but what you do see is autolysis or some disintegration of these tubular epithelial cells. So the findings are varied, but they seem to be related to the virus directly infecting the kidney. This is ultrastructural findings or electron microscopy. The panel here, panel A here, shows lower magnification. This here is the tubular basement membrane. These are tubular epithelial cells, and I'm not a pathologist either. I fancy myself as somewhat of an amateur renal pathologist, but you'll just have to take my word for it. These are proximal tubular epithelial cells. I think what you can see though is a number of vacuoles, and this here arrow here points to tiny viral particles that you can appreciate better in this panel B. These are intracellular endoplasmic viral particles or viral arrays. A higher power magnification here, you can actually see in the inset here in the corner what clearly looks like the SARS-CoV-2 virus with the viral envelope with crown-like projections. So the authors are pretty sure here that these are viral particles. And another finding that they think clearly demonstrates virus infecting the kidney is these vacuoles with double membrane vesicles that also appear to be viral particles close to the rough endoplasmic reticulum with ribosomes, suggesting that some viral replication and assembly is happening right here within the proximal tubule. So that's evidence of direct infiltration and infection of the kidney by the viral particles, and not just kidney injury related to cytokine release and hemodynamics. This here is a slide that illustrates collapsing glomerulopathy in patients with COVID-19. Collapsing glomerulopathy is also known as collapsing focal and segmental glomerular sclerosis. It is a variety of glomerular injury that leads to nephrotic syndrome and frequently acute decline in kidney function. And what you see here is the glomerulus. And I'm sure all of you know that these are, this is the afferent and the afferent arteriole here. These are renal capillary loops, glomerular capillary loops. And these here are the renal podocytes, which form the an important part of the filtration barrier that prevents protein from spilling out in the urine. And what happens in collapsing glomerulopathy is a hypertrophy of these podocytes that leads to compression and collapse of the renal microvasculature in the glomerulus, and also a destruction of the filtration barrier that leads to proteinuria. That's what happens in collapsing FSGS. There's a number of conditions that lead to collapsing FSGS. They include HIV that causes a condition known as HIVAN, or HIV-associated nephropathy, infection related to several viruses like CMV, EBV, parvovirus B19 can all lead to collapsing glomerulopathy. What all of these conditions have in common is an increased level of the cytokine interferon gamma in the bloodstream that is thought to cause a disruption of the podocytes by causing podocyte dedifferentiation. Now, why do I talk about all of this? It seems like in patients with COVID-19 infection, there is a similar mechanism of injury that leads to collapsing glomerulopathy. As we all know, COVID-19 is a condition that is associated with cytokine release, and one of those cytokines is interferon. Interferon seems to upregulate expression of an apolipoprotein called ApoL1 that then leads to podocyte injury and collapsing FSGS. So this is the purported mechanism of direct injury caused by the virus in patients with collapsing FSGS. And I think understanding this mechanism can give us some insights into what could potentially be done to prevent this in certain patients or treat it in those patients in whom this condition has arisen. I'll talk briefly about management of these patients who develop dialysis requiring acute kidney injury. And I say briefly only because at the end of the day, managing patients with COVID who develop acute kidney injury and who need dialysis is in many ways similar to the management of patients who require dialysis for other reasons. But it is different in certain subtle ways, and I hope to draw your attention to that in the next few minutes. one, attention needs to be paid to the volume status more so than in general, because there is a tendency in these patients with COVID and pneumonia to dry them out, so to speak, to adopt a conservative fluid management strategy, because pulmonologists will tell you that in patients with acute lung injury and acute, respiratory distress syndrome, it is important to be conservative with fluid administration. But you can take that too far, and that can lead to acute kidney injury. So it is important for us as clinicians to make sure we're not overdoing diuresis in patients with COVID pneumonia. Co-localization of patients on a medical floor or in an ICU is a no-brainer, but it bears repeating, both to avoid the spread of the infection within the hospital, but also to be more judicious about the use of a scarce resource, namely the dialysis technicians and dialysis nurses, who have borne the brunt of this pandemic as well, along with all of us. The utility of peritoneal dialysis really became evident to us early on during the COVID pandemic, because we ran out of dialysis machines. We pride ourselves to be, a hospital that's, well resourced, but we were no match when the COVID cases kept climbing in early 2020, and we ran out of acute hemodialysis machines, as well as continuous renal replacement therapy, or CRRT machines. And a number of patients, were actually well served and perhaps even saved, because we switched them over to peritoneal dialysis after inserting peritoneal dialysis catheters. And I think, especially in a setting where we're scarce in resources, peritoneal dialysis was a godsend for some of these patients. Anticoagulation becomes an important part of the management of these patients, because, as you know, COVID-19 seems to be a hypercoagulable state, and dialysis circuits and dialysis filters tend to clot, even in non-COVID patients. And we saw a lot of filter clotting, or requiring discard of dialysis equipment during the peak of the pandemic. And we could quickly realize that unless there was an absolute contraindication, we have to be really particular about systemic or regional anticoagulation in these patients who require dialysis. Now, a number of nephrology societies suggest that in patients who require dialysis, the first line therapy should be to offer continuous renal replacement therapy, which is CRRT, which even to me sounds impractical. I'm a proponent of CRRT for a number of conditions, but these machines are expensive and a scarce resource. But in an ideal world, using CRRT machines for the purpose of dialyzing these patients is suitable, because these machines are portable. They do not require water hookup and plumbing, and all you need is replacement fluid and dialysis solution bags. And so these machines can go to the patient rather than the patient come to the dialysis unit. And in doing so, by which I mean in not allowing the patients to be moved around in the hospital, you minimize chances of exposing other patients. So in an ideal world, you can use CRRT, and there are certain other indications for CRRT. There are suggestions that because the mechanism of toxin clearance in CRRT is through convective clearance rather than diffusive clearance, without getting into the weeds, it's more likely to remove some of the cytokines that are associated with sepsis and perhaps can decrease morbidity in these patients. So that's another reason that certain societies seem to suggest that CRRT is the way to go in these patients. However impractical it may be. Kind of switching gears a little bit, I'm going to talk about long COVID. Long COVID has been called by several names. One of them is that seems to be in vogue right now is PASC, or post-acute sequelae of SARS-CoV-2. You know what? We know what the acute manifestations are in patients with COVID-19. They have been well characterized. But what happens to patients who have recovered is not clear. And this is a study that was done in the US across several Veterans Administration hospitals. This was a multi-center retrospective cohort study that included thousands of patients who had actually survived COVID hospitalization beyond 30 days and were followed up to 6 months. And these patients were compared to propensity-matched controls. And the aim of the study was to determine the association between COVID and development of acute kidney injury, chronic kidney disease, and urinary tract infections after the 30-day mark from when they were diagnosed with COVID. And you'll see here, somewhat surprisingly, at least in the early days of COVID, when we thought patients who recovered from the acute illness would do fine, and then when we began to see some of these chronic manifestations, this came as a surprise. And this was one of these early studies that demonstrated that, basically showing high odds of developing acute kidney injury as well as chronic kidney disease in patients who had recovered from COVID, 30 days to 6 months after their initial diagnosis. These odds are approximately 2 to 5% for developing acute kidney injury and about 1.5 to 2% for developing chronic kidney disease. And the odds are also similarly high for developing urinary tract infection, which is surprising to me. I'm not sure why COVID would lead to development of UTIs. Perhaps these patients are in the hospital and they're catheterized, and that leads to downstream risk of UTIs. That would be my speculation. This is a graphic illustration of the time course of evolution of kidney function in patients with COVID-19 in the long term, or long COVID, and its relation to kidney disease. The x-axis here is time after infection with the novel coronavirus. The y-axis here is kidney function, or GFR, if you will. The blue line here represents what would happen normally in a normal individual. And as you can see, the kidney function seems to decline over the years. And that's not surprising, because it's a well-known fact, at least in the nephrology community, that senescence is associated with a decline in kidney function. The red line here is what happens in patients with COVID. This part of the graph here is an acute decline in kidney function in those who develop acute kidney injury. Some of them have a complete recovery, and their trajectory resembles those without COVID. This is line number 3 here. Line 4 is actually a manifestation of a progressive decline in kidney function, leading to chronic kidney disease and end-stage kidney disease. And I would surmise that this is because of subclinical inflammation and injury that may persist for months after the acute infection, resulting in a progressive decline in kidney function. This trajectory here represents those patients who seem to have a relapsing and a recurring course of several episodes of acute kidney injury. And this here is those who never recover renal function after their initial insult with AKI. who end up on dialysis. So it's a varied outcome, and it seems to linger even after the initial infection is cured. Again, it's important to understand the mechanisms of what leads to long COVID. And I alluded to this before. There could be direct injury with the virus infecting the kidney itself. There could be collapsing FSGS. Something I hadn't mentioned earlier is complement-mediated injury to the renal microvasculature. This is the renal endothelium. This is the virus that seems to somehow activate complement that culminates in the assembly of the membrane attack complex that leads to recruitment of anaphylatoxins and inflammatory cells that cause injury to the vascular endothelium, cell death that then leads to microthrombi within the kidney and necrosis. And I just wanted to draw your attention to this because there are FDA or approved medications that can target the complement cascade and potentially prevent kidney injury in these patients. So to gain a better understanding of the effects of COVID-19 on the kidney, it's important that large integrated healthcare systems collaborate with each other and that they're able to rapidly collect data and analyze data and to try to understand what the risk factors are for developing various long-term sequelae of COVID, and then to try and prevent and mitigate those illnesses. So the National Institutes of Health, which is the funding agency for research in the United States, has recently launched the study known as the RECOVER study, or the Research COVID to Enhance RECOVER study, solely focused on trying to understand long COVID, or PASC. And this is a multi-center observational study that's trying to collect granular data, like I said, to understand, to prevent, and to treat post-acute sequelae of SARS-CoV-2. And the institution where I work at was fortunate to be designated the clinical science core for this study. And I have a small role in trying to understand kidney disease in the long term after COVID-19 infection. Which leads me, I guess, to talk a little bit more about a slightly different aspect of kidney disease, and that's hypertension. And if I could paraphrase Hamlet from William Shakespeare, who said, "To be or not to be." One of the conundrums early on in the COVID-19 pandemic amongst hospital physicians, nephrologists, cardiologists, and many others was the question of whether to use ACE inhibitors or not. And that was the question in patients with COVID-19. This was a hot topic. And I'll quickly point you to what the conundrum was. This is the renin-angiotensin aldosterone system. We all know how that works and how ACE inhibitors block angiotensin converting enzyme 1 and prevent vasoconstriction, and they have a role to play in salt and water balance. What is less well known is the renin-angiotensin system has certain unhealthy or insalubrious effects that can lead to tissue injury and lung injury in COVID-19 patients. And ACE2 is angiotensin converting enzyme 2, which seems to mitigate this risk by breaking down angiotensin 1 and 2 to certain products that seem to oppose RAS-mediated tissue injury. Early on during the pandemic, it was animal studies led to the understanding that ACE2, in fact, is a membrane-bound receptor within the alveolar epithelial cells in the lung and acts as a receptor for the spike protein of the SARS-CoV-2 virus. And that leads to the entry of the virus into the alveolar epithelium and replication of the virus. So it looked like a greater expression of ACE2 wasn't a good thing because it could lead to increased viral replication. There were other animal studies that showed that ACE inhibitors can in fact increase expression of ACE2 receptor in the lung. So obviously, ACE inhibitors and angiotensin receptor blockers were discouraged, or at least some did early on during the pandemic. But it turns out there are some pros to using these agents, because as I said in earlier, ACE2 seems to have, in addition to the to acting as a receptor for the virus, ACE2 breaks down angiotensin 1 and protects against RAS-mediated lung injury. And it turns out that the pros of blocking the RAS system outweigh the cons, and it now looks like there is no indication to discontinue ACE inhibitors and angiotensin receptor blockers in patients who have hypertension and have COVID-19. And this was demonstrated in a number of studies, and I'm just going to point our attention to a couple of important studies. One came out of Wuhan, China. It was, again, a cohort study, 1,000 patients. They compared those in whom ACE inhibitors were discontinued versus those in whom they weren't, and it looked like the mortality was actually higher in those patients in whom these drugs were discontinued, suggesting that it wasn't a good idea to stop these drugs. And this here to the right is data from New York City, the Bronx. This was a paper published by Dr. Chilumuri's group that, again, a single center retrospective study that looked at 400 odd patients from an ethnic minority population in the Bronx in New York. And they compared controls to, in whom ACE inhibitors were discontinued to those in whom these drugs were not, and it looked like outcomes, if anything, were slightly better in those in whom ACE inhibitors were continued. And I'll quickly talk about the relationship between end-stage kidney disease and COVID-19. This is the prevalence of ESRD in the United States. There's about 600,000 patients on dialysis in the US. It kind of mirrors what's the state of affairs in India. There's about 200,000 patients on dialysis in the US. Nearly 200,000 new patients develop kidney failure in India every year. A majority of them, a great majority of them, are on hemodialysis, and a small percentage of them are on peritoneal dialysis. And it actually appears that India is doing much better in terms of cutting costs for providing dialysis to these patients, because I can tell you that costs in the US are tenfold these numbers, and that's merely a reflection, I guess, of ballooning healthcare costs in the US. This is data from Columbia University Medical Center in New York City that looked at outcomes in patients with ESRD who developed COVID. And I'll quickly draw your attention to the mortality of 31% in patients with ESRD who were admitted to the hospital. 31% did not make it out of the hospital. And they died at a median time point of 6 days after admission to the hospital. And the risk factors seem to be older age and higher inflammatory markers. So clearly, ESRD, COVID causes excess mortality in patients with ESRD. This is Centers for Disease Control data that actually gives out a monthly morbidity and mortality report that predicts the number of patients with ESRD who would die in any given month. And in blue here is the predicted mortality, and in black here is the actual observed deaths. And as you can see, in March, April, and May 2020, deaths peaked, and there was a significant excess mortality as a result of COVID in patients with end-stage kidney disease. This is data from France, just to again reiterate the fact that this is a global disease. This is how COVID cases climbed in France in early 2020. And the French National Registry undertook a study that looked at the risk factors for acquiring COVID in patients with ESRD. And what they found was interesting. What they found was that in-center hemodialysis patients are at a higher risk for catching COVID than those who were getting dialysis at home. And you might ask me, who are these patients who are getting dialyzed at home? These are patients who are on peritoneal dialysis or on, in certain instances, home hemodialysis. So patients who come to the dialysis center seem to be at a higher risk because it is difficult to observe physical isolation and infection control. So several organizations, the American Society of Nephrology, the International Society of Nephrology, and the CDC came up with several guidelines. Some of these are pretty practical guidelines that one can implement in dialysis centers to prevent spread of COVID-19. As you all know, patients with kidney disease, both acute and chronic kidney disease, have a high prevalence of anemia, and a great majority of them receive erythropoietin or similar drugs to bring up their hemoglobin. But these drugs come with certain disadvantages or downstream effects, namely increased risk for thrombotic events, MI, stroke. So an important question that arose in COVID-19 is, what is the target hemoglobin in patients with ESRD and acute kidney injury? And it turns out that the target may be a little lower in patients with COVID-19 because they are a hypercoagulable state, and you need to balance the risk of thrombosis to the risk of developing disabling anemia and need for blood transfusion. Blood transfusions, of course, can be associated with a small risk of infection, but as a nephrologist, what I'm concerned about is every single blood transfusion increases exposure to HLA antigens, which can make a future transplant difficult if these patients end up on dialysis. Vaccine efficacy in patients on dialysis seems to be a little lower than in the general population. This is a study from Israel where patients received the Pfizer vaccine. And I'll show you here that among the 160 dialysis patients who got 2 doses of the Pfizer vaccine, 10% or 16 patients were negative for the spike protein antibody, and they had lower titers of spike protein antibodies. And in fact, a small percentage of them had breakthrough COVID, possibly because they never developed antibodies. Fortunately, at least in this study, the rate of vaccine hesitancy in dialysis staff was low. But it behooves us to encourage vaccination among dialysis patients if vaccines are available, and also to encourage vaccination among all healthcare staff who work in dialysis units. And I'll finally switch gears to talk quickly about what happens in transplant patients and what happened to transplant patients during the peak of COVID. This is the cover of the American Journal of Transplantation circa July 2020, basically showing the coronavirus enveloping the world, which is sort of how we felt. We felt like we were under siege with COVID because there was a steep drop in organ transplants, not just kidneys, but all organ transplants in the US and I'm sure around the world. There was a 50% decline in deceased donor transplants. 71% of kidney transplant centers actually shut down their living donor transplant programs, and a great majority of them imposed some sort of restrictions on who they were transplanting. I'm happy to say the situation has changed now, but that was a grim reality at that point. Transplant patients are on immunosuppressive medications. These are potent drugs that prevent rejection, but have severe side effects in terms of infections and cancer. So there was a major concern early on about whether these patients were at a higher risk of developing poorer outcomes than the general population. And this is data from a French cohort of 100 patients who are propensity matched to controls, and kidney transplant patients compared to controls don't seem to have an increased mortality. This is Kaplan-Meier curves showing similar mortality in kidney transplant recipients and controls. And this here shows similar severe disease-free survival in kidney transplant recipients when compared to controls. And in this study, severe disease was defined as either death or requiring admission to the ICU. So the bottom line here being transplant recipients, despite being on immunosuppressive medication, don't seem to do any worse than the general population, even after adjustment or matching for a number of confounding variables. And I'll finally conclude by quickly talking about vaccine efficacy in transplant patients. Much of my clinical work in my daily practice is actually taking care of transplant patients. And I struggle to explain to some of our patients here how important it is for them to get vaccinated. And in fact, it's more important for transplant recipients to get vaccinated than the general population, because they don't seem to respond to the vaccine as well as the general population. In fact, their response is worse than ESRD patients who I alluded to earlier, seem to have a negative response in about 10%. But you'll see here in this study published in the New England Journal a few months ago, that after the first dose, that is before the second dose, only 4% of transplant recipients develop an antibody response. And after the second dose, only 40% develop a response. So that's a majority of patients who are not immune after the second dose. And it looks like there seems to be a somewhat higher response after a third dose of 70%. Even that's not perfect, but it is an improvement on this abysmal rate of 4 and 40%. So in the US, and I think many countries around the world, healthcare agencies are recommending that transplant recipients get a booster dose. So this is the state of affairs right now in India and in the US. And I pulled this from Google a few hours ago, and it looks like we have, dare I say, blunted these curves, and I hope it remains this way. One aspect of work that we do as physicians and a medical community that we maybe have neglected in the last year or so is research, other than researching what happens to COVID patients. And we've relegated a number of research pursuits to lower down the ladder. And as a result of these curves now looking better, at our institution, we were able to go back to do some research. And I just wanted to share some news that maybe some of you have heard. This is some of my colleagues here, surgical colleagues, and actually, I should say my boss in the middle of that picture, operating on a deceased donor/recipient, implanting a pig kidney, and conducting a first attempt at a xenotransplant to alleviate organ shortage. So, and I think hopefully we can, in the next several months, cautiously move past COVID, or at least learn to live with COVID, and begin to do something that that can improve the lives of our patients. I'd like to conclude by saying thank you, and although I couldn't be there for this talk, I hope to visit Visakhapatnam sometime soon and be there in person. Happy to take questions or discuss, and I'm happy to hear your insights. Thank you.
Thank you very much, Vasistha. That was very comprehensive. You addressed a lot of the aspects of COVID. I'm going to ask for some comments, and I already have several questions that was on the chat box. So let me take care of those first. Dr. Buddharaju, I saw your questions as per the request. You want to pose them yourself or shall I read? You asked yourself.
All right, I thought you wanted me to pose some practical questions. So I think Vani had a question about increased maternal mortality in India as well as here from COVID-19 infections. I think that's from the small studies that we have, the mortality is primarily a reflection of the severity of disease. The more severe the COVID-19 infection is, the higher chance of mortality. The risk of preeclampsia and eclampsia is much higher during COVID-19 infections in pregnancy. So the questions I had was, there's some talk about vaccine-associated nephropathy with the mRNA vaccines. There's not firm established data about it, about cause-effect relationship. I'm wondering if Dr. Raviraj could comment on any increased glomerular disease with the non-mRNA vaccines that they're using in India. That was my first question. The second one was, in dialysis patients with end-stage renal disease, there seems to be a higher risk of circuit thrombosis, right? And I'm wondering how they're managing it here, protocols here versus protocols in India to deal with that. I think I'll start with that.
Shall I tell about? Thank you, Vasishtha, for your very comprehensive and elaborate talk on COVID-19 and kidney. Dr. Buddharaj has asked me one question. I think Vasishtha is the right one to answer because we have no experience with Pfizer vaccines in India. We have only experience with Covishield and Covaxin. We have seen a couple of, there are two types of, reactivation of glomerular nephritis that can happen. One is it can be a de novo. Those who did not have glomerular disease before, they can have glomerular disease following a vaccination, or they can have a relapse. Those suffering from some kind of a glomerulonephritis, they can develop a relapse of the disease either after the first dose or after the second dose. We have seen some people relapsing with minimal lesion nephropathy following first dose of vaccination. So we had a problem whether to give the second dose or not to give the second dose. But as far as the studies go, we can continue with the second dose also. This is what I feel. And I think Vasishtha is the one who can tell more about the Pfizer vaccine and the mRNA vaccines and the relation to glomerulonephritis, as well as to the therapy of glomerular diseases following COVID-19 infections, whether to give immunosuppression or withhold immunosuppression and wait.
Okay. Vasishtha, he had another.
Yeah, I can jump in. Yeah, I think there's certainly been case reports of de novo or recurrent glomerular disease after vaccination. But these have been case reports and these are anecdotal, and I think it's difficult to infer causation and probably not even correlation from the really minuscule data that we have. And I was just looking at some, some society guidelines that suggest that we don't overplay these instances of rare instances of glomerular disease that seem to be developing after the vaccine, and push on with recommending vaccination. And in terms of how to manage patients with pre-existing glomerular disease or newly diagnosed glomerular disease. Should they get immunosuppression? That's a I think topic for discussion in of itself. That I think several. Take a while to discuss that, but it depends what the disease we're talking about is. Conditions that can be treated with agents like calcineurin inhibitors, cyclosporin, and tacrolimus can and should be treated without any change because these drugs don't seem to adversely impact outcomes. But conditions that need to be treated with antimetabolites like cyclophosphamide, which is used in a lot of lupus patients, patients with post-immune glomerulonephritis, and other antimetabolites like mycophenolate, azathioprine, these seem to have adverse impact. And it has been suggested that the doses of these agents be lowered if the patients are already on these agents. And if there's an opportunity to perhaps delay initiation of these drugs in patients who have been newly diagnosed, then that is also recommended. Well, that's easier said than done.
But in order to take this further and study it, I was just curious. I am not aware of the data. What about other infections, other viruses? Is there a vaccine-associated nephropathy following flu vaccine, following other vaccines? Is there any empirical data or just a couple of anecdotes? Do you know?
That's a good question. I think, again, it's anecdotal, but the strongest evidence for vaccine-related glomerular disease is the strongest association seems to be with minimal change disease. That's been in textbooks for a long time. But I don't think that has changed or, recommendations and guidelines for vaccine administration. Because I think, as with many of these side effects from vaccines, the incidence of these adverse events is so low that I think at least the big picture is that the benefits outweigh risks.
Okay.
Yeah, I think there are few case reports of ANCA-associated vasculitis and IgA nephropathy, but they're barely just about the general population risk, and so it's difficult to assume anything. And that's why I was asking if any of the non-mRNA vaccines are doing something similar. Looks like not much there either. The other question I had was in the oncology setting, we're kind of gone away from using B-cell depletion therapy for maintenance for lymphomas and stuff like that. So, you frequently give, ATG, both T-cell and B-cell depleting agents to transplant recipients, right? So in oncology, we're delaying the vaccination by about 3 months, at least, when we give B-cell depleting agents. What are the current guidelines as far as solid organ transplants are concerned for vaccinating transplanted patients?
Yeah, so the scenario in transplant recipients is slightly different than perhaps oncology, because patients who require these drugs, thymoglobulin, which is a T-cell depleting agent, and rituximab, B-cell depleting agent. Thymoglobulin is used as induction therapy for transplant. So the patients get these drugs at the time of transplant. And it's indicated for patients who are HLA sensitized. So the risk of developing a high-grade rejection by not giving thymoglobulin seems to, at least now, with the current level of prevalence in the community spread, the risk of a rejection by not using thymoglobulin seems to be greater than the risk of developing COVID-19, at least now. So we are pushing on. We're giving thymoglobulin for whenever it is indicated for transplant recipients. But of course, as I mentioned early on, this was the major concern when at the height of the pandemic. And that's why we had to basically stop all living donor transplants and really cut back on deceased donor transplants and be selective about who we were transplanting at the peak of the pandemic. So it's a numbers game right now, and it seems like we're going back to where we used to be. We're not using induction therapy any less frequently. And I think the same goes to agents like rituximab, because in transplant patients, rituximab, and also in patients with glomerular disease like ANCA disease, rituximab is used to treat rejection or induce remission. And not using those drugs in those situations will mean sacrificing kidney function, we will be unable to salvage kidney function.
Yeah.
So I think
so my question was basically, after you give ATG, how long do you wait until you give the first shot of the vaccine? And if they've already gotten the first shot before the transplant, how long do you wait to give the second shot after you give ATG induction?
Yeah, so that's, sorry if I misunderstood your question. So after ATG, we're waiting for 3 months to begin the vaccine regimen. Now, if they've already received 1 dose before, we're actually recycling, the vaccine regimen. And we would again wait for 3 months and start with the first dose, give the second dose a month later, and potentially give a booster dose a month after that.
Okay.
Thank you.
Dr. Buddharaj, you had one more question, although I thought it was a trick question. When the resources are overwhelmed for dialysis, what do? You meant in the Indian scene or New York City?
Oh,
well, I hope we don't face that situation again. I think both US and India had that situation. So I was wondering about techniques that small town hospitals could use into simple things like maybe increasing the flow rate. How do you optimize the available machines, that kind of stuff, practical stuff.
Yeah, the flow rate, I guess, could be increased in CRRT, which again is sort of something that's the domain of big hospitals and big city hospitals. I'm sure CRRT machines are available everywhere now, but you can certainly increase flow rates. We were rotating CRRT machines between patients, 24 hours with one patient and moving it to another patient, giving one patient a break. We were doing 12 hours on, 12 hours off. We were certainly doing that. Because as you know, hospitals are always at capacity, and we sometimes do that even in non-COVID situations. But certainly during the height of COVID, we were splitting, quote unquote, splitting CRRT machines between patients. One thing which we thought we would never do, and we did do, is peritoneal dialysis. Our surgeons, and I think in India, probably a lot of nephrologists put in acute peritoneal dialysis catheters. I wish I could say the same about our practice here, but we don't. Surgeons put in peritoneal dialysis catheters. And we did a lot of peritoneal dialysis, both manual and, using cycler machines. And one sort of a weird, we were pushed to do this. As you know, a lot of these patients are prone, seems to improve lung mechanics. So we were in situations where we had patients who were on the ventilator, they were prone, and, we were doing peritoneal dialysis in prone patients. So desperate times call for desperate measures.
That is a good segue into the other question. I thought this beast has been put to death. When is the right time of indication for cytosorb filtration in COVID patients with cytokine storm? Can we use IL-6 quantification for initiating cytosorb filtration? Is that used at all?
I can only say we have not used it. I think cytosorb is more of a a thing in Europe. I certainly haven't used it. I'm probably not. I don't have any expertise to, to probably shed any more light on this. All I can say is that I have read from reliable sources that it isn't recommended because, yeah, I'll leave it at that.
Yeah, there's no role for cytosorb or machines like that for COVID. There's no data to suggest that there's any benefit from it. We tried using it with cytokine release syndrome that we see with CAR T cell therapy and stuff like that. We usually get fairly good results with agents like tocilizumab these days for CRS associated with CAR T cell therapy. So there's absolutely no role for cytosorb. People in India were actually using it, and I would think that's a kind of exploitation.
I thought that issue was dead. So with you available on the screen with Dr. Chillamuri there, I thought we could kill this beast forever. Yes, Sridhar?
The Chinese have used it with some limited benefit. It's not used in the United States at all.
Is there any trial or a study that they can refer to, or it was used?
Yeah, there's a Chinese publication where they tried this. So there is a paper where they tried it, but with no really convincing results. So, and that's where everybody left it, and nobody's doing this now.
Dr. Buddharaju, you had already addressed the question from Dr. Vani about maternal deaths, right?
Go ahead and ask Vashisht what he thinks. How do you manage a post-renal transplant pregnant patient? I think that's the issue. First of all, the first question is pregnant women are more prone to get acute renal failure when they have COVID? Is that your observation?
Thankfully, I haven't had a pregnant transplant patient who has had COVID. I think the data are limited. I don't think pregnancy itself is a risk factor or is associated with increased incidence of COVID. But certainly managing these patients poses challenges.
Yeah. So our experience, I think somebody commented that the death is from renal function, renal failure. That's not true. The most common reason why they die is respiratory dysfunction. And it's partly because the diaphragm is compromised in a term pregnant woman. And actually it's more ARDS that they have than acute renal failure. You do see acute renal failure, but there is no, at least in American experience, it is not much more common to have acute renal failure. It's usually acute respiratory failure and also secondary bacterial infections. A pregnant woman, for some reason, has altered immune status. And when they get COVID, they get secondary bacterial infections on top of a bad pneumonia. So that's the cause of death. The other thing is they do get thrombocytopenia. So thrombotic microangiopathies during pregnancies are fairly common. So COVID may exacerbate that. So that we see, and renal failure associated with that we see sometimes. But per se, pregnancy and COVID, I don't think there's an increased risk of renal failure.
Vashisht, Dr. Prem Kumar has a question because of the use of remdesivir and beta-cyclodextrin that can cause renal dysfunction, or can we just go ahead with remdesivir treatment?
I think the trials that led to the widespread use of remdesivir didn't include, at least initially, patients with low GFR. So we weren't using remdesivir, or at least we were avoiding remdesivir. But I don't know that remdesivir by itself causes kidney injury. I could be wrong about it, but I don't see an absolute contraindication to using remdesivir.
Sridhar, you want to take a crack at it?
So we don't use remdesivir once there's a renal failure. And if the patients are on statins or tacrolimus, let's say the post-transplant, remdesivir causes toxic myopathies on them. So being as it is, the renal function is compromised and they're on drugs which potentiate toxicity of remdesivir, we will not use it. So if the renal function is compromised, we have no experience using remdesivir at all. In a few patients, one or two pregnant patients, we attempted to try it. They developed bradycardia as soon as we gave the first dose of remdesivir, and we aborted it at that point. So we are not using, so it is for us a contraindication to use remdesivir once the renal function is compromised.
I totally agree with that. Not once you have a low GFR, I think we haven't been using it either.
Yeah.
So Dr. Chilumuri, has use of remdesivir come down in your hospital? I don't see our hospital is using that much of remdesivir anymore. In fact, in the last 3 or 4 weeks, very rarely I've seen remdesivir being used with the advent of monoclonal antibodies. And I think we might be we were part of the either Merck or Pfizer, but more or less, I think they've almost stopped using remdesivir from what I'm seeing.
We use it still unless there's contraindication. It's still part of our protocol to use remdesivir, unless there's a contraindication not to use it.
Dr. Kairam, shall I add a little information to this? So we have been using remdesivir. Vasishtha said, of course, low GFR, below 20 mils. They have not studied remdesivir. So that's why a lot of people are not using remdesivir in renal failures. But the question in that is remdesivir as such is not nephrotoxic. The vehicle which is used along with that, the cyclodextrin, is nephrotoxic. So in the doses which you use remdesivir, the vehicle, remdesivir has two forms. One is the solid, the powder form, the other one is the liquid form. So the liquid form will not have much cyclodextrin in that. The powder form will have more. But in the dose which you use, like 200 milligrams on day one and 100 milligrams subsequently, the amount of cyclodextrin that accumulates in the body is not toxic to the cells. So that is why we have been using remdesivir in the regular doses, even in people with end-stage renal failure. We haven't found any problem with that. And cyclodextrin is dialysable. So that way also it has some advantage. So we have used remdesivir in a child also. We have published that recently. A post-transplant 9-year-old boy who had COVID, we gave him remdesivir.
Okay. Post-transplant.
Post-transplant. Yep, of course, renal function was normal.
Yeah. In post-transplant, my only concern is if they're already on tacrolimus and statins, and then you add remdesivir, that's the worrisome. If you could stop statins, I think in a kid, they probably are not on statins, but many of the adult post-transplants are on statins, and that's the worry that the 3-drug combination could be toxic.
Vasishtha, you see another question in the chat box. You may have already addressed it. I wasn't paying attention. In post-renal transplant pregnant patient, if COVID infected, what are the options for transplant rejection prevention?
So I think it sort of mirrors what we would do in non-pregnant patients, right? We continue immunosuppression. We lower the dose of antimetabolites. So I'll step back. I'll say the standard regimen for a transplant recipient has 3 pillars. One is tacrolimus or cyclosporin, which are calcineurin inhibitors. The second drug we use is mycophenolate or azathioprine, which are antimetabolites, and then prednisone in most instances. It doesn't appear that tacrolimus doesn't appear to increase risk of adverse outcomes in patients with COVID. In fact, there are some animal studies that suggest that tacrolimus might decrease viral replication. So we don't change the dose of tacrolimus. What we do is certainly decrease the dose, typically cut in half the dose of mycophenolate in any patient who's sick enough to be hospitalized with COVID. And in patients who are critically ill, we discontinue the antimetabolite, which is, I think, what we would do also in pregnant patients. These are maintenance immunosuppressive drugs. We would have to hope that lowering immunosuppression in the setting of COVID doesn't precipitate a rejection. And if they do develop rejection, whether they're pregnant or not, it becomes challenging to treat rejection with ongoing COVID, because that will involve treatment with big guns like T cell, B cell depleting agents and plasmapheresis. So it is a challenging situation.
I'm going to reserve the last question to myself. I want to ask you.
Let me add, Ram, let me ask both the father and the son this question. So we are seeing that when you start vaccinating people who are chronic renal failures and ESRDs, we're seeing an increased rate of thrombocytopenia in them, especially those who are borderline thrombocytopenia.
Honestly, I have to say I have no expertise on this. Perhaps I'll defer this to my father.
So we have not personally seen any thrombocytopenia following vaccination. So I'm not very sure about this.
Yeah, I think it's something we should start looking. Yeah, I think we should start looking, because as more and more people got vaccinated, to see, and in some they actually bleed. That's how low the platelets count go.
So
typically they're older individuals. Often they have maybe other rheumatological illnesses or other autoimmune illnesses maybe. But we see a fair drop of platelet counts in them.
So Chilimuri, what I've seen is in my practice, I see quite a few thrombocytopenias after vaccination, including end-stage renal disease. There seems to be an immune-mediated component, and they seem to be responding to routine ITP therapy like steroids and stuff like that. And a lot of times it tends to be transient. We have seen some bleeding rarely, but yeah, I mean, just like all other patients who have gotten vaccine, and we're seeing increased incidence of ITP, we see that in this population as well. So it might be an immune-mediated phenomenon.
Okay. I have a question. You know, in the beginning, this is a predominantly respiratory disease. When we were hearing its extraordinary pulmonary pathology, we began to understand the role of the microthrombi and thrombotic disease. Similarly, I was actually trying to read this morning about what is the site of injury. Is it the nephron, or what are the systems that have ACE2 receptor, portal of entry? Are there thrombotic disease? Because in your slide that showed 42 kidneys in pathology autopsy, only 6 had focal fibrin thrombi. So is there a very small role for microthrombi within the renal capillaries, or is it direct injury of the nephron itself, as you showed in the EM pictures?
So I think the microthrombi, if I were to guess, again, at this point, it's mostly conjecture, right? Even the Columbia study that did those 42 autopsies, the conjecture is that there is complement activation, that leads to, membrane attack complex, essentially drilling holes in the vascular endothelium, releasing prothrombotic factors that leads to thrombotic microangiopathy. That seems to be the mechanism of injury. But there are also studies that have shown that, I think I showed you EM pictures of virus within the tubular epithelium. But there are other studies that have shown that the viral particles were found in the vascular endothelium. And I think it's conceivable that they might set off certain signaling cascades that can make the micro environment more thrombophilic. Or it may be a part of the whole systemic hypercoagulable state itself. Maybe not specific to the kidney, and there's no ongoing injury within the kidney. Maybe it's something that's systemic. Perhaps either Dr. Chilumuri or Dr. Buddharaju perhaps can comment on the tendency for, or the predisposition for blood clots in these patients.
Yeah, so we've looked at this, we see reduced complement levels. So there's certainly some element of complement-mediated thrombotic microangiopathy. That brings me to the next question. At NYU, have you tried anti-complement therapy like eculizumab in some of these Covet patients? Or we talked about it, but never really got to starting a trial.
Yeah, what ends up happening is most of these patients don't get biopsied. Certainly the really sick ones early on, who were in the ICU on a ventilator in shock, perhaps older with a lot of comorbidities, we felt biopsying those patients was not worth the risk. And even the data we have, as you saw, was from autopsy studies, not biopsy in living patients. So honestly, I can tell you we've not used eculizumab or any other anti-complement agent in these patients. But there may come a time when, we have evidence-based therapies that are, drugs that allow patients to go past the stage where they're suffering from acute COVID pneumonia, but they're surviving long enough to have these renal sequelae, and they might be the patients that we would feel comfortable biopsying. And perhaps if we then see complement activation, not just TMA on the biopsy, but actual complement on immunofluorescence, perhaps then there would be a role for. And as you know, these drugs are among the most expensive drugs in the world. So that's another sort of barrier towards using these drugs.
All right, at this point, even though you have been very thorough and comprehensive, we do have only so much time. So I would like to end this after thanking you profusely for the time you spent preparing for it and the clarity with which you presented your data. And Senior Tatapudi Garu, thank you for introducing your boy to us. And Sudhakar.
Yeah. Okay, please go ahead.
Yes, I was just referring to that post-vaccination thrombocytopenia. Sometime back on the same forum, we had Dr. Naveen from Steel Plant presenting a case that's available on the YouTube. And Sridhar was referring to that we have to be more vigilant and towards that. So Dr. Naveen from Steel Plant has already presented the data that he had from the steel plant. This is just for the information. And sir, would you like to say something, Dr. Raviraj?
No, Dr. Kairam is talking. Let him.
Yeah.
No, I was asking Dr. Sudhakar to say good night to us and good day to all of you.
Yeah. If there are no further questions for the comments, I thank Dr. Vasishta profusely for such an elaborate presentation and answering all the queries. And if you see the chat box, you can understand the amount of attention that was paid by most of the people who have logged in. Thank you very much. Thank you, Sridhar, for your expert comments. Dr. Buddharaju for coming back again, and Dr. Raviraju and Dr. Radha. for logging in, and Dr. Raviraju for sharing his experience. Thank you all once again. And thank you, Dr. Kairam. And we'll meet next week at the same time with, I think it's the psychiatrist this time. And we'll have the physician burnout predominantly being talked about during that session. Thank you all. Good night to all of you over there, and good day for all those who are in India.
Thank you, Buddharaju. And
Thank you.
Thank you.
Good job, Vashisht. Very well done.
Thank you, Dr. Chilmuri.
Bye-bye.
So, thank you very much, Dr. Kairam and Dr. Sridhar. Thank you very much.
Oh, by the way, I wanted to tell you,
Yeah.
Dr. Ravindranath Sharma was driving all the way from Atlanta to North Carolina. He was in the car all the time. And now he's hosting a party with a bunch of children. He said, Dr. Kairam, I wouldn't have missed it, but I got a bunch of kids around me, so he begged for excuse.
No problem. Sridhar
Okay.
has, so it's an honor for Vasishtha that Sridhar is there, and then he moderated along with you.
It's a special privilege to see your student do very well.
Thank you very much.
Okay, bye-bye.
Thank you very much, Sridhar, for bringing up him to this level. Thank you.
Thank you. Bye-bye.
Thank you. Wait, stop. You have the lady sitting on your right side and you're thinking, Sridhar, what's the matter with you?
As it
Well,
is a lurker.
Bye-bye.
Bye.
Thank you.
Good evening.
Thank you very
Thank
much.
you.